fibrosis may also be observed. Similar lesions may be found in older individuals without diabetes, apparently as part of normal aging. An increase in the number and size of islets is especially characteristic of non-diabetic newborns of mothers with diabetes. Presumably, fetal islets undergo hyperplasia in response to the maternal hyperglycemia. Diabetic macrovascular disease. Diabetes exacts a heavy toll on the vascular system. Endothelial dysfunction, which predisposes to atherosclerosis and other cardiovascular morbidities, is widespread in diabetes, as a consequence of the deleterious effects of persistent hyperglycemia and insulin resistance on the vascular compartment. The hallmark of diabetic macrovascular disease is accelerated atherosclerosis involving the aorta and large and medium-sized arteries. The morphology of atherosclerosis in patients with diabetes is indistinguishable from that in individuals without diabetes. Myocardial infarction, caused by atherosclerosis of the coronary arteries, is the most common cause of death in diabetes. Gangrene of the lower extremities, as a result of advanced vascular disease, is about times more common in diabetes patients than in the general population. The larger renal arteries are also subject to severe atherosclerosis, but the most damaging effect of diabetes on the kidneys is exerted at the level of the glomeruli and the microcirculation. Hyaline arteriolosclerosis, the vascular lesion associated with essential hypertension, is both more prevalent and more severe in patients with diabetes than those without, but it is not specific for diabetes and may be seen in older patients without hypertension. It takes the form of an amorphous hyaline thickening of the wall of the arterioles, which causes narrowing of the lumen. Not surprisingly, in diabetic patients, it is related not only to the duration of the disease but also to the level of blood pressure. Diabetic microangiopathy. One of the most consistent morphologic features of diabetes is diffuse thickening of basement membranes. The thickening is most evident in the capillaries of the skin, skeletal muscle, retina, renal glomeruli, and renal medulla. However, it may also be seen in such non-vascular structures as renal tubules, the Bowman capsule, peripheral nerves, and placenta. It should be noted that despite the increase in the thickness of basement membranes, capillaries in patients with diabetes are leakier than normal to plasma proteins. The microangiopathy underlies the development of Figure 24.35 insulitis, shown here from a rat model of autoimmune diabetes, also seen in type 1 human diabetes. Amyloidosis of a pancreatic islet in type 2 diabetes, figured 24.36, severe renal hyaline arteriolosclerosis. Note a markedly thickened, tortuous afferent arteriole. The amorphous nature of the thickened vascular wall is evident. Diabetic nephropathy, retinopathy, and some forms of neuropathy. Diabetic nephropathy. The kidneys are prime targets of diabetes. Renal failure is second only to myocardial infarction as a cause of death. Figure 24.37 electron micrograph of a renal glomerulus showing markedly thickened glomerular basement membrane in a diabetic. L. Glomerular capillary lumen, U. Urinary space. Figure 24.38 renal cortex showing thickening of tubular basement membranes in a diabetic patient. From this disease, 3 lesions are encountered. Glomerular lesions, renal vascular lesions, principally arteriolosclerosis, and pyelonephritis, including necrotizing papillitis. The most important glomerular lesions are capillary basement membrane thickening, diffuse mesangial sclerosis, and nodular glomerulosclerosis. Capillary basement membrane thickening. Widespread thickening of the glomerular capillary basement membrane occurs in virtually all cases of diabetic nephropathy and is part and parcel of diabetic microangiopathy. Capillary basement membrane thickening is best appreciated by electron microscopy. Morphometric studies demonstrate that thickening begins as early as 2 years after the onset of T1D, and by 5 years amounts to about a 30% increase. These progressive changes in the GBM are usually accompanied by mesangial widening and thickening of the tubular basement membranes. Figure 24.39 diffuse and nodular diabetic glomerulosclerosis. Note the diffuse increase in mesangial matrix and characteristic acellular PAs positive nodules. Diffuse mesangial sclerosis. This lesion consists of diffuse increase in mesangial matrix. The matrix depositions are PAs positive. As the disease progresses, the mesangial matrix deposits may take on a nodular appearance. The progressive expansion of the mesangium has been shown to correlate well with measures of deteriorating renal function, such as increasing proteinuria. Nodular glomerulosclerosis. This is also known as intercapillary glomerulosclerosis or Kimmel-Steele-Wilson disease. The glomerular lesions take the form of ovoid or spherical, often laminated PAs positive nodules of matrix situated in the periphery of the glomerulus. They lie within the mesangial core of the glomerular lobules and may be surrounded by patent peripheral capillary loops or loops that are markedly dilated. The nodules often show features of mesangial lysis, defined by disruption of anchoring interactions between the capillaries and the mesangial stalks. The loss of these support structures may lead to the formation of capillary microaneurysms. While not all the lobules in individual glomeruli are involved by nodular lesions, even uninvolved lobules and glomeruli show striking diffuse mesangial sclerosis. The nodular lesions are frequently accompanied by prominent accumulations of hyaline material in capillary loops or adherent to Bowman capsules. Both afferent and efferent glomerular hilar arterioles show hyalinosis. As a consequence of the glomerular and arteriolar lesions, the kidney becomes ischemic, develops tubular atrophy and interstitial fibrosis, and usually contracts in size. Approximately 15% to 30% of individuals with long-term diabetes develop nodular glomerulosclerosis, and in most instances it is associated with renal failure. Renal atherosclerosis and arteriolosclerosis also contribute to renal dysfunction in patients with diabetes. Hyaline arteriolosclerosis affects not only the afferent but also the efferent arteriole. Such efferent arteriolosclerosis is rarely, if ever, encountered in individuals who do not have diabetes. Pyelonephritis is an acute or chronic inflammation of the kidneys that usually begins in the interstitial tissue and then spreads to affect the tubules. Both the acute and chronic forms of this disease are more common and more severe. Figure 24.40, nephrosclerosis in a patient with long-standing diabetes. The kidney has been bisected to demonstrate both diffuse granular transformation of the surface and marked thinning of the cortical tissue. Additional features include some irregular depressions, the result of pyelonephritis, and an incidental cortical cyst. In patients with diabetes than in the general population, one special pattern of acute pyelonephritis, papillary necrosis, is much more prevalent in diabetes patients than in those without diabetes. Diabetic ocular complications. The eye is profoundly affected by diabetes mellitus. The architecture and microanatomy of the eye are discussed in Chapter 29. Diabetes-induced hyperglycemia leads to acquired opacification of the lens, a condition known as cataract. Long-standing diabetes is also associated with increased intraocular pressure and resulting damage to the optic nerve. The most profound ocular changes of diabetes are seen in the retina. The retinal vasculopathy of diabetes mellitus can be classified into background diabetic retinopathy and proliferative diabetic retinopathy. Diabetic neuropathy. The prevalence of peripheral neuropathy in individuals with diabetes depends on the duration of the disease. Up to 50% of diabetes patients overall have peripheral neuropathy clinically, and up to 80% of those who have had the disease for more than 15 years. This is discussed further in Chapter 27. Clinical manifestations of chronic diabetes. Table 24.7 summarizes some of the pertinent clinical, genetic, and histopathologic features that distinguish T1D and T2D. In both types, it is the long-term effects of diabetes, rather than acute metabolic complications, that are responsible for much of the morbidity and mortality. In most instances, these complications appear approximately 15 to 20 years after the onset of hyperglycemia. The severity of chronic complications is related to both the degree and the duration of hyperglycemia, as evidenced by the attenuation of endorgan damage by effective glycemic control in prospective studies. Macrovascular complications such as myocardial infarction, renal vascular insufficiency, and cerebrovascular accidents are the most common causes of mortality in long-standing diabetes. Patients with diabetes have a 2 to 4 times greater incidence of coronary artery disease and a 4-fold higher risk of dying from cardiovascular complications than age-matched individuals without diabetes. An elevated risk for cardiovascular disease is even observed in patients with prediabetes. Significantly, myocardial infarction is almost as common in women with diabetes as in men. In contrast, myocardial infarction is uncommon in women of reproductive age without diabetes. Diabetes is often accompanied by underlying conditions that favor the development of adverse cardiovascular events. For example, hypertension is found in approximately 75% of individuals with T2D and potentiates the effects of hyperglycemia and insulin resistance on endothelial dysfunction and atherosclerosis. Another cardiovascular risk frequently seen in diabetes patients is dyslipidemia, which includes both increased triglycerides and LDL levels and decreased levels of the protective lipoprotein, high-density lipoprotein. Insulin resistance is believed to contribute to diabetic dyslipidemia by favoring the hepatic production of atherogenic lipoproteins and by suppressing the uptake of circulating lipids in peripheral tissues. Diabetic nephropathy is a leading cause of end-stage renal disease in the United States. Approximately 30% to 40% of all patients with diabetes develop clinical evidence of nephropathy. Development of end-stage renal disease is more likely with TD than TD. But because of the greater prevalence of TD, these patients constitute slightly over one-half of the patients with diabetes starting dialysis each year. The progression from overt nephropathy to end-stage renal disease is highly variable, but by 20 years, more than 75% of patients with T1D and approximately 20% of those with T2D with overt nephropathy will develop end-stage renal disease, requiring dialysis or renal transplantation. The likelihood of diabetic nephropathy is greatly influenced by ethnicity. For example, Native Americans, Hispanics, and African Americans have a greater risk of developing end-stage renal disease than do non-Hispanic Caucasians with T2D. These differences are suspected to be genetic in origin, but responsible genes have yet to be identified. The earliest manifestation of diabetic nephropathy is the appearance of low amounts of albumin in the urine. Without specific interventions, approximately 80% of patients with T1D and 20% to 40% of patients with T2D will develop overt nephropathy with macroalbuminuria over 10 to 15 years, usually accompanied by the appearance of hypertension. Visual impairment, including total blindness, is one of the more feared consequences of long-standing diabetes. Approximately 60% to 80% of patients develop some form of diabetic retinopathy approximately 15 to 20 years after diagnosis, and diabetic retinopathy is the leading cause of adult blindness in the United States. The fundamental lesion of retinopathy, neovascularization, is attributable to hypoxia-induced expression of VEGF in the retina. Current treatment for this condition includes administration of anti-angiogenic agents that block the action of VEGF. As stated earlier, patients with diabetes also have an increased propensity for glaucoma and cataract formation, which also contribute to visual impairment. Diabetic neuropathy can result in damage to the central nervous system, peripheral sensoromotor nerves, and the autonomic nervous system. It most frequently takes the form of a distal symmetric polyneuropathy of the lower extremities that affects both motor and sensory function. Over time, the upper extremities may be involved as well, thus approximating a glove and stocking pattern of polyneuropathy. Other forms include autonomic neuropathy, which produces disturbances in bowel and bladder function and sometimes erectile dysfunction, and diabetic mononeuropathy, which may manifest as sudden foot drop, wrist drop, or isolated cranial nerve palsies. Patients with diabetes are plagued by enhanced susceptibility to infections of the skin and to tuberculosis, pneumonia, and pyelonephritis. Such infections cause the deaths of about 5% of these patients. In an individual with diabetic neuropathy, a trivial infection in a toe may be the first event in a long succession of complications that ultimately leads to death. The basis of enhanced susceptibility is multifactorial and includes decreased neutrophil function and impaired cytokine production by macrophages. The vascular compromise also impairs the delivery of immune cells and molecules to sites of infection. The staggering societal and economic impact of diabetes has already been discussed. For the most part, diabetes remains a lifelong disease, although pancreatic islet cell transplantation has the potential to ameliorate T1D for many patients. For some individuals with T2D, dietary modifications, exercise, and weight loss regimens can reduce insulin resistance and hyperglycemia at least early in the disease. However, all patients will ultimately require some form of therapeutic intervention to maintain glycemic control. Key concepts: diabetes mellitus, pathogenesis, and long-term complications. T1D is an autoimmune disease characterized by progressive destruction of islet beta cells, leading to absolute insulin deficiency. T1D stems from a failure of self-tolerance in T cells, and circulating autoantibodies to islet cell antigens often are detected in affected patients. T2D has no autoimmune basis. Instead, features central to its pathogenesis are insulin resistance and beta cell dysfunction, resulting in relative insulin deficiency. Obesity has an important relationship with insulin resistance, mediated through multiple factors including excess FFAs, cytokines released from adipose tissues, and inflammation. Monogenic forms of diabetes are uncommon and are caused by single gene defects that result in primary beta cell dysfunction or lead to abnormalities of insulin receptor signaling. The long-term complications of diabetes are similar in both types and involve 4 potential mechanisms resulting from sustained hyperglycemia: formation of AGEs, activation of PKC, disturbances in the polyol pathways leading to oxidative stress, and overload of the hexosamine pathway. Long-term complications of diabetes include both large vessel disease such as atherosclerosis, ischemic heart disease, and lower extremity ischemia, as well as small vessel disease, the latter manifesting mainly as retinopathy, nephropathy, and neuropathy. Pancreatic neuroendocrine tumors. The preferred term for tumors of the pancreatic islet cells is pancreatic neuroendocrine tumors or PANETs. They are rare in comparison with tumors of the exocrine pancreas, accounting for 2% of all pancreatic neoplasms. PANETs can occur anywhere within the pancreas or in the immediate peripancreatic tissues. They resemble their counterparts, carcinoid tumors, found elsewhere in the alimentary tract. These tumors may be single or multiple and benign or malignant. Pancreatic endocrine neoplasms often elaborate pancreatic hormones but are sometimes non-functional. Like other endocrine neoplasms, it is difficult to predict the behavior of a PANET based on its light microscopic appearance alone, although tumors with a higher proliferation index can have an aggressive biological potential. Unequivocal criteria for malignancy include metastases, vascular invasion, and local infiltration. The functional status of the tumor has some impact on prognosis, in that approximately of insulin-producing tumors are benign, and 2 of other functioning and non-functioning pancreatic endocrine neoplasms are malignant. Fortunately, insulinomas are the most common subtype of pancreatic endocrine neoplasms. Pathogenesis. The genome of sporadic PANETs recently has been sequenced, with identification of recurrent somatic alterations in 3 major genes or pathways. MEN1, which causes familial MEN syndrome, type 1, also is mutated in some sporadic neuroendocrine tumors. Loss of function mutations in tumor suppressor genes, such PTEN and TSC2, which result in activation of the oncogenic mammalian TOR signaling pathway. Inactivating mutations in 2 genes, alpha thalassemia, mental retardation syndrome, X-linked and death domain, associated protein, which have multiple cellular functions including telomere maintenance. PANETs with DAX or ATRX mutations demonstrate a phenomenon known as alternative lengthening of telomeres, which allows telomeres to be maintained in neoplastic cells that do not express telomerase. Of note, nearly 1/2 of PANETs have a somatic mutation in either ATRX or DAX, but not both, consistent with their function in the same oncogenic pathway. The 3 most common and distinctive clinical syndromes associated with functional pancreatic endocrine neoplasms are hyperinsulinism, hypergastrinemia, and the Zolling-Urelison syndrome, and MEN. Hyperinsulinism. Beta cell tumors are the most common pancreatic endocrine neoplasms and often produce sufficient insulin to induce clinically significant hypoglycemia. The characteristic clinical picture is dominated by hypoglycemic episodes, which occur when the blood glucose level falls below mg/dl. Clinical manifestations include confusion, stupor, and loss of consciousness. These episodes are precipitated by fasting or exercise and are promptly relieved by feeding or parenteral administration of glucose. Morphology. Insulinomas are most often found within the pancreas and are usually benign. Most are solitary, although multiple tumors may be encountered. Bona fide carcinomas, making up only about 10% of cases, are diagnosed on the basis of local invasion and distant metastases. On rare occasions, an insulinoma may arise in ectopic pancreatic tissue. In such cases, electron microscopy reveals the distinctive granules of beta cells. Solitary tumors are usually small, encapsulated, pale to red-brown nodules located anywhere in the pancreas. Histologically, these benign tumors look remarkably like giant islets, with preservation of the regular cords of monotonous cells and their orientation to the vasculature. Malignant tumors are also well differentiated, and they may be deceptively encapsulated. Deposition of amyloid is a characteristic feature of many insulinomas. Hyperinsulinism may also be caused by focal or diffuse hyperplasia of the islets. This change is found occasionally in adults but is far more commonly encountered as congenital hyperinsulinism, hypoglycemia in neonates and infants. Several clinical scenarios may result in islet hyperplasia, including maternal diabetes, Beckwith-Wiedemann syndrome, and rare mutations in the cell K-channel protein or sulfonylurea receptor. In maternal diabetes, the fetal islets respond to hyperglycemia by increasing their size and number. In the postnatal period, these hyperactive islets may be responsible for serious episodes of hypoglycemia. This phenomenon is usually transient. Clinical features. While up to 80% of islet cell tumors demonstrate excessive insulin secretion, the hypoglycemia is mild in all but about 20%, and many cases never become clinically symptomatic. The critical laboratory findings in insulinomas are high circulating levels of insulin and a high insulin-to-glucose ratio. Surgical removal of the tumor is usually followed by prompt reversal of the hypoglycemia. Figure 24.4. 1. Pancreatic endocrine neoplasm. The neoplastic cells are monotonous and demonstrate minimal pleomorphism or mitotic activity. There is abundant amyloid deposition, characteristic of an insulinoma. Clinically, the patient had episodic hypoglycemia. It is important to note that there are many other causes of hypoglycemia besides insulinoma. The differential diagnosis includes such conditions as abnormal insulin sensitivity, diffuse liver disease, inherited glycogenosis, and ectopic production of insulin by certain fibromas and fibrosarcomas. Depending on the clinical circumstances, hypoglycemia induced by self-injection of insulin should also be considered. Zollinger-Ellison syndrome. Marked hypersecretion of gastrin usually has its origin in gastrin-producing tumors, which are just as likely to arise in the duodenum and peripancreatic soft tissues as in the pancreas. There has been lack of agreement regarding the cell of origin of these tumors, although it seems likely that endocrine cells of either the gut or the pancreas could be the source. Zollinger and Ellison first called attention to the association of pancreatic islet cell lesions, hypersecretion of gastric acid, and severe peptic ulceration, which are present in 90% and 95% of patients. Morphology. More than half of gastrin-producing tumors are locally invasive or have already metastasized at the time of diagnosis. In approximately 25% of patients, gastrinomas arise in conjunction with other endocrine tumors as part of the MEN1 syndrome. MEN1-associated gastrinomas are frequently multifocal, while sporadic gastrinomas are usually single. As with insulin-secreting tumors of the pancreas, gastrin-producing tumors are histologically bland and rarely show marked anaplasia. Adrenal glands. The adrenal glands are paired endocrine organs consisting of a cortex and a medulla, which differ in their development. In the Zollinger-Ellison syndrome, hypergastrinemia gives rise to excessive gastric acid secretion, which in turn causes peptic ulceration. The duodenal and gastric ulcers are often multiple. Although they are identical to those found in the general population, they are often unresponsive to therapy. In addition, ulcers may occur in unusual locations such as the jejunum. When intractable jejunal ulcers are found, Zollinger-Ellison syndrome should be considered. Clinical features. Treatment of Zollinger-Ellison syndrome involves control of gastric acid secretion by use of H+K+APase inhibitors and excision of the neoplasm. Total resection of the neoplasm when possible eliminates the syndrome. Patients with hepatic metastases have a shortened life expectancy, with progressive tumor growth leading to liver failure, usually within 10 years. Other rare pancreatic endocrine neoplasms. Alpha cell tumors are associated with increased serum levels of glucagon and a syndrome consisting of mild diabetes mellitus, a characteristic skin rash, and anemia. They occur most frequently in perimenopausal and postmenopausal women and are characterized by extremely high plasma glucagon levels. Delta cell tumors are associated with diabetes mellitus, cholelithiasis, steatorrhea, and hypochlorhydria. They may be very difficult to localize preoperatively. High plasma somatostatin levels are required for diagnosis. Vipoma induces a characteristic syndrome that is caused by release of vasoactive intestinal peptide from the tumor. Some of these tumors are locally invasive and metastatic. A very important person assay should be performed on all patients with severe secretory diarrhea. Neural crest tumors such as neuroblastomas, ganglioneuroblastomas, and ganglioneuromas, and pheochromocytomas can also be associated with the Vipoma syndrome. Pancreatic carcinoid tumors producing serotonin and an atypical carcinoid syndrome are exceedingly rare. Pancreatic polypeptide-secreting endocrine tumors present as mass lesions as even high plasma levels of this hormone fail to cause symptoms. Some pancreatic and extrapancreatic endocrine tumors produce two or more hormones. In addition to insulin, glucagon, and gastrin, pancreatic endocrine tumors may produce ACH, MSH, ADH, serotonin, and norepinephrine. These multi-hormonal tumors are to be distinguished from the MEN syndromes, in which a multiplicity of hormones is produced by tumors in several different glands. Structure and function. In essence, the cortex and medulla are two glands packaged into one structure. The adrenal cortex has three zones. Beneath the capsule is the narrow layer of zona glomerulosa. An equally narrow zona reticularis abuts the medulla. Intervening is the broad zona fasciculata, which makes up about 75% of the total cortex. The adrenal cortex synthesizes three different types of steroids: glucocorticoids, which are synthesized primarily in the zona fasciculata and to a lesser degree in the zona reticularis; mineralocorticoids, the most important being aldosterone, which is generated in the zona glomerulosa; and sex steroids, which are produced largely in the zona reticularis. The adrenal medulla is composed of chromaffin cells, which synthesize and secrete catecholamines, mainly epinephrine. Catecholamines have many effects that allow rapid adaptations to changes in the environment. Adrenal cortex. Diseases of the adrenal cortex can be conveniently divided into those associated with hyperfunction and those associated with hypofunction. Adrenocortical hyperfunction. The syndromes of adrenal hyperfunction are caused by overproduction of the three major hormones of the adrenal cortex. Cushing syndrome, characterized by an excess of cortisol, hyperaldosteronism as a result of excessive aldosterone, and adrenogenital or virilizing syndromes caused by an excess of androgens. The clinical features of these syndromes overlap somewhat because of the overlapping functions of some of the adrenal steroids. Hypercortisolism, pathogenesis. This disorder is caused by conditions that produce elevated glucocorticoid levels. Cushing syndrome can be broadly divided into exogenous and endogenous causes. The vast majority of cases of Cushing syndrome are the result of the administration of exogenous glucocorticoids. The endogenous causes can in turn be divided into those that are ACH-dependent and those that are ACH-independent. ACH-secreting pituitary adenomas account for 60% to 70% of cases of endogenous hypercortisolism. The pituitary form of this syndrome is referred to as Cushing disease. The disorder affects women about 4 times more frequently than men and occurs most frequently in young adults. In the vast majority of cases, it is caused by an ACH-producing pituitary microadenoma. In some cases, there is an underlying macroadenoma, and rarely there is corticotroph cell hyperplasia without a discrete adenoma. Corticotroph cell hyperplasia may be primary or arise secondarily from excessive stimulation of ACT release by a hypothalamic corticotrophin-releasing hormone-producing tumor. The adrenal glands in individuals with Cushing disease are characterized by variable degrees of nodular cortical hyperplasia caused by the elevated levels of ACH. The cortical hyperplasia, in turn, is responsible for hypercortisolism. Secretion of ectopic ACTH by non-pituitary tumors accounts for about 5% to 10% of ACT-dependent Cushing syndrome cases. In many instances, the responsible tumor is a small cell carcinoma of the lung, although other neoplasms, including carcinoids, medullary carcinomas of the thyroid and panates, have been associated with the syndrome. In addition to tumors that elaborate ectopic ACH, occasionally a neuroendocrine neoplasm may produce ectopic CRH, which in turn causes ACH secretion and hypercortisolism. As in the pituitary variant, the adrenal glands undergo bilateral cortical hyperplasia, but the rapid downhill course of patients with these cancers often limits the extent of the adrenal enlargement. This variant of Cushing syndrome is more common in men and usually occurs in the 40 seconds and 50 seconds. Primary adrenal neoplasms, such as adrenal adenoma and carcinoma, are the most common underlying causes of ACH-independent Cushing syndrome. The biochemical sine qua non of ACT-independent Cushing syndrome is elevated serum levels of cortisol with low levels of ACH. Cortical carcinomas tend to produce more marked hypercortisolism than adenomas or hyperplasias. Recent large-scale gene sequencing studies have helped define the molecular features of adrenocortical carcinomas, including recurrent activating mutations of beta-catenin and inactivating mutations of TP53, MEN1, and PRKAR1A. Interestingly, PRKAR1A mutations are observed in both adrenocortical adenomas and carcinomas, as well as in micronodular hyperplasia, suggesting shared molecular mechanisms and ontogeny are at play in these cortisol-secreting lesions. Primary cortical hyperplasia is much less common than ACH-dependent adrenal cortical hyperplasia. In bilateral macronodular adrenal hyperplasia, the nodules are usually greater than 10 mm in diameter. Familial forms associated with germline mutations in the armadillo repeat-containing gene, a putative tumor suppressor gene, have been reported. Of note, up to of apparently sporadic BMA cases harbor germline ARMC mutations with somatic loss of the second allele in the hyperplastic nodules. In true sporadic cases of BMAA, nodular hyperplasia is not entirely autonomous. Specifically, cortisol production is regulated by hormones other than ACH because of ectopic overexpression of the corresponding GG protein. Coupled hormone receptors in the hyperplastic adrenocortical cells. Implicated hormones other than ACTH include gastric inhibitory peptide, LH, and ADH. The mechanism by which these receptors are overexpressed is not known, but epigenetic changes may be involved. A subset of BMA arises in the setting of McCune-Albright syndrome, a multisystemic disease characterized by germline mutations that activate GNAS, which encodes a stimulatory G-sulfa. This G-alpha mutation causes hyperplasia by increasing intracellular levels of CAMP, which you will recall is an important second messenger in many endocrine cell types. ACTH-independent bilateral hyperplasia can also be micronodular, and these arise mainly in two settings: primary pigmented nodular adrenocortical disease, or as part of the so-called Carney complex, a multisystem syndrome resulting in both endocrine and non-endocrine neoplasms. Both primary pigmented nodular adrenocortical disease and Carney complex are most. Table 24.8 Causes of endogenous Cushing syndrome. Most frequent sources of ectopic ACTH syndromes are small cell lung carcinoma and neuroendocrine tumors of lung, thymus, and pancreas. Less frequent causes include medullary thyroid carcinoma, gastrinoma, pheochromocytoma, prostate carcinoma, and several others. BIN bilateral macronodular adrenal hyperplasia tissues, autocrine and paracrine ACTH might be produced and contribute to cortisol secretion. If confirmed by in vivo studies, the ACTH-independent classification will need to be modified in the future. Commonly associated with mutations of the regulatory subunit of CAMP-dependent protein kinase, which, like activating GNAS mutations, act by increasing intracellular CAMP levels. Morphology. The main lesions of Cushing syndrome are found in the pituitary and adrenal glands. The pituitary shows changes regardless of the cause. The most common alteration, resulting from high levels of endogenous or exogenous glucocorticoids, is termed Crook-Hyaline change. In this condition, the normal granular basophilic cytoplasm of the ACTH-producing cells in the anterior pituitary becomes homogeneous and paler. This alteration is the result of the accumulation of intermediate keratin filaments in the cytoplasm, a finding that is also seen in Crook cell corticotroph adenoma. Depending on the cause of the hypercortisolism, the adrenals show one of the following abnormalities: cortical atrophy, diffuse hyperplasia, macronodular or micronodular hyperplasia, and an adenoma or carcinoma. In patients in whom the syndrome results from exogenous glucocorticoids, suppression of endogenous ACTH results in bilateral cortical atrophy due to a lack of stimulation of the zona fasciculata and reticularis by ACTH. The zona glomerulosa is of normal thickness in such cases, because this portion of the cortex functions independently of ACTH. In contrast, in cases of endogenous hypercortisolism, the adrenals either are hyperplastic or contain a cortical neoplasm. Diffuse hyperplasia is found in individuals with ACTH-dependent Cushing syndrome. Both glands are enlarged, either subtly or markedly, weighing up to 30 grams. The adrenal cortex is diffusely thickened and variably nodular, although the latter is not as pronounced as seen in cases of ACTH-independent nodular hyperplasia. Microscopically, the hyperplastic cortex demonstrates an expanded lipid pore zona reticularis, comprising compact eosinophilic cells, surrounded by an outer zone of vacuolated lipid-rich cells, resembling those seen in the zona fasciculata. Any nodules present are usually composed of vacuolated lipid-rich cells, which account for the yellow color of diffusely hyperplastic glands. In contrast, in macronodular hyperplasia, the adrenals are almost entirely replaced by prominent nodules of varying sizes, which contain an admixture of lipid poor and lipid-rich cells. Unlike diffuse hyperplasia, the areas between the macroscopic nodules also demonstrate evidence of microscopic. Figure 24.42. Diffuse hyperplasia of the adrenal gland contrasted with a normal adrenal gland. In cross-section, the hyperplastic adrenal cortex is yellow and thickened, and a subtle nodularity is seen in this gland from a patient with ACTH-dependent Cushing syndrome. Nodularity. Micronodular hyperplasia is composed of 1 to 3 mm darkly pigmented micronodules with atrophic intervening areas. The pigment is believed to be lipofusin, a wear and tear pigment. Primary adrenocortical neoplasms causing Cushing syndrome may be malignant or benign. Functional adenomas or carcinomas are not morphologically distinct from non-functioning adrenal neoplasms. Both the benign and malignant lesions are more common in women in their 30 to 50 seconds. Adrenocortical adenomas are yellow tumors surrounded by thin or well-developed capsules, and most weigh less than 30 grams. Microscopically, they are composed of cells that are similar to those encountered in the normal zona fasciculata. The carcinomas associated with Cushing syndrome, by contrast, tend to be larger than the adenomas. These tumors are unencapsulated masses frequently exceeding 200 to 300 grams in weight that have all of the anaplastic characteristics of cancer. With functioning tumors, both benign and malignant, the adjacent adrenal cortex and that of the contralateral adrenal gland are atrophic, as a result of suppression of endogenous ACTH by high cortisol levels. Clinical features. Cushing's syndrome develops slowly and its onset may be subtle. Early stages may present with hypertension and weight gain. With time, the more characteristic central pattern of adipose tissue deposition becomes apparent in the form of truncal obesity, moon facies, and accumulation of fat in the posterior neck and back. Hypercortisolism causes selective atrophy of fast-twitch myofibers, resulting in decreased muscle mass and proximal limb weakness. Glucocorticoids induce gluconeogenesis and inhibit the uptake of glucose by cells, with resultant hyperglycemia, glucosuria, and polydipsia. The catabolic effects cause loss of collagen and resorption of bones. Consequently, the skin is thin, fragile, and easily bruised, wound healing is poor, and cutaneous striae are particularly common in the abdominal area. Bone resorption results in the development of osteoporosis, with consequent backache and increased susceptibility to fractures. Persons with Cushing syndrome are at increased risk for a variety of infections because glucocorticoids suppress the immune response. Additional manifestations. Figure 24.4. 3 micronodular adrenocortical hyperplasia with prominent pigmented nodules in the adrenal gland. On histologic examination, the nodules are composed of cells containing lipofuscin pigment, seen in the right part of the field. Table. Clinical features of Cushing syndrome. In children. Modified from Newell-Price-Bertaga X, Grossman A.B., Niemann L.K. Cushing syndrome Lancet. Figure 24.4. A patient with Cushing syndrome demonstrating central obesity, moon facies, and abdominal striae. Includes several mental disturbances, including mood swings, depression, and frank psychosis, as well as hirsutism and menstrual abnormalities. The laboratory diagnosis of Cushing syndrome is based on the following: the 24-hour urine-free cortisol concentration, which is increased, and loss of normal diamal pattern of cortisol secretion. Determining the cause of Cushing syndrome depends on measurement of the serum ACH and the dexamethasone suppression test, in which urinary steroid excretion is measured after administration of the glucocorticoid dexamethasone. The results of these tests fall into 3 patterns. In pituitary Cushing syndrome, the most common form, ACH levels are elevated and are not suppressed by the administration of a low dose of dexamethasone. Hence, there is no reduction in urinary excretion of 17-hydroxycorticosteroids. After higher doses of injected dexamethasone, however, the pituitary responds by reduced EACH secretion, which is reflected by suppression of urinary steroid secretion. Ectopic ACH secretion results in an elevated level of ACH, but its secretion is completely insensitive to low or high doses of exogenous dexamethasone. When Cushing syndrome is caused by an adrenal tumor, the ACH level is quite low because of feedback inhibition of the pituitary. As with ectopic ACH secretion, both low-dose and high-dose dexamethasone fail to suppress cortisol excretion. Key concepts. Hypercortisolism. The most common cause of hypercortisolism is exogenous administration of steroids. Endogenous hypercortisolism most often is secondary to an ACH-producing pituitary microadenoma, followed by primary adrenal neoplasms and perineoplastic ACH production by tumors. The morphologic features in the adrenal vary from bilateral cortical atrophy to bilateral diffuse or nodular hyperplasia to an adrenocortical neoplasm. Primary hyperaldosteronism. Hyperaldosteronism is the generic term for a group of closely related conditions characterized by chronic excess aldosterone secretion. Hyperaldosteronism may be primary, or it may be secondary to an extra-adrenal cause. Primary hyperaldosteronism stems from an autonomous overproduction of aldosterone, with resultant hypertension, suppression of the renin-angiotensin system, and decreased plasma renin activity. Primary hyperaldosteronism is caused by one of 3 conditions: bilateral idiopathic hyperaldosteronism, characterized by bilateral nodular hyperplasia of aldosterone-secreting zona glomerulosa cells of the adrenal glands, is the most common underlying cause, accounting for about 60% of cases, most of which are sporadic. Individuals with bilateral idiopathic hyperaldosteronism tend to be older and to have less severe hypertension than those presenting with adrenal neoplasms. The molecular basis of this entity remains unclear, although recent studies suggest that a minority of patients harbor germline mutations of KCNJ, consistent with their being part of a subtype that is now classified as familial hyperaldosteronism, type 3. Figure 24.45. The major causes of primary hyperaldosteronism and its principal effects on the kidney. Adrenocortical neoplasm, either an aldosterone-producing adenoma or, rarely, an adrenocortical carcinoma. In approximately 35% of cases, primary hyperaldosteronism is caused by a solitary aldosterone-secreting adenoma, a condition referred to as Conn syndrome. This condition occurs most frequently in mid-adult life and is more common in women than in men. Recent gene sequencing studies have helped elucidate the genomic landscape of aldosterone-producing adenomas. Up to harbor somatic mutations of KCNJ, which encodes a potassium ion channel protein known as GERK expressed in zona glomerulosa cells. GERK4 mutations result in loss of selectivity of the channel to potassium ions, leading to nonspecific influx of sodium and subsequent calcium-dependent activation of the aldosterone synthase enzyme. Disruption of intracellular ion homeostasis in zona glomerulosa cells is a common theme with other somatic mutations observed in aldosterone-producing adenomas as well. These include mutations in CACNA1H, which encodes a calcium channel, and AT1A1, which encodes a sodium-potassium exchanging ATPase. The functional consequence of these mutations is to maintain cells in a chronic state of depolarization, resulting in autonomous aldosterone synthesis. Familial hyperaldosteronism accounts for approximately 5% of cases. 4 distinct subtypes have been described, of which FHI, or glucocorticoid-remediable aldosteronism, is the most common. FHI stems from a rearrangement in chromosome 8 that places CYP11B2 under the control of the ACEth-responsive CYP11 bone gene promoter. ACT8 thus stimulates the synthesis of aldosterone synthase from the chimeric gene. Because in this unusual circumstance aldosterone production is under the control of ACTH, it is suppressible by dexamethasone. The remaining 3 subtypes of FH are rare, with FH3 being ascribed to germline KCNJ5 mutations and FHIV to germline CACNA1H mutations, 2 genes that are also somatically mutated in subsets of aldosterone-secreting adenomas. In secondary hyperaldosteronism, in contrast, aldosterone release occurs in response to activation of the renin-angiotensin system. It is characterized by increased levels of plasma renin and is encountered in conditions such as the following: decreased renal perfusion, arterial hypovolemia and edema, pregnancy, morphology. Aldosterone-producing adenomas are almost always solitary, small, well-circumscribed lesions, more often found on the left than on the right. They tend to occur in the SNS, and in women more often than in men. They are often buried within the gland and do not produce visible enlargement, making them difficult to locate by imaging. They are bright yellow on cut section and, surprisingly, are composed of lipid-laden cortical cells that more closely resemble fasciculata cells than glomerulosa cells. In general, the cells tend to be uniform in size and shape. Occasionally, there is modest nuclear and cellular pleomorphism. A characteristic feature of aldosterone-producing adenomas is the presence of eosinophilic, laminated cytoplasmic inclusions, known as spironolactone bodies, found after treatment with the antihypertensive drug spironolactone. In contrast to cortical adenomas associated with Cushing's syndrome, those associated with hyperaldosteronism do not usually suppress ACH secretion. Therefore, the adjacent adrenal cortex and that of the contralateral gland are not atrophic. Bilateral idiopathic hyperaldosteronism is marked by diffuse and focal hyperplasia of cells resembling those of the normal zona glomerulosa. The hyperplasia is often wedge-shaped, extending from the periphery toward the center of the gland. The enlargement may be subtle, and as a rule an adrenocortical adenoma must be carefully excluded as the cause for hyperaldosteronism. Clinical features. With an estimated prevalence rate of 5% to 10% among non-selected hypertensive patients, primary hyperaldosteronism may be the most common cause of secondary hypertension. The prevalence of hyperaldosteronism increases with the severity of hypertension, reaching nearly 20% in patients who are classified as having treatment-resistant hypertension. Through its effects on the renal mineralocorticoid receptor, aldosterone promotes sodium reabsorption, which secondarily increases the reabsorption of water, expanding the extracellular fluid volume and elevating cardiac output. The long-term effects of hyperaldosteronism-induced hypertension are cardiovascular compromise and an increase in the prevalence of adverse events such as stroke and myocardial infarction. Hypokalemia was considered a mandatory feature of primary hyperaldosteronism, but increasing numbers of normal kalemic patients are now diagnosed. Hypokalemia results from renal potassium wasting and, when present, can cause a variety of neuromuscular manifestations, including weakness, paresthesias, visual disturbances, and occasionally frank tetany. The diagnosis of primary hyperaldosteronism is confirmed by elevated ratios of plasma aldosterone concentration to plasma renin activity. If this screening test is positive, a confirmatory aldosterone suppression test is performed, as many other disorders can alter the plasma aldosterone and renin ratios. In primary hyperaldosteronism, the therapy varies according to cause. Adenomas are amenable to surgical excision. In contrast, surgical intervention is not very beneficial in patients with bilateral hyperplasia, which often occurs in children and young adults. These patients are best managed medically with an aldosterone antagonist such as spironolactone. The treatment of secondary hyperaldosteronism rests on correcting the underlying cause of the hyperactivity of the renin-angiotensin system. Adrenogenital syndromes. Disorders of sexual differentiation, such as virilization or feminization, can be caused by primary gonadal disorders and several primary adrenal disorders. The adrenal cortex secretes dihydroepiandrosterone and androstenedione, two compounds that can be converted to testosterone in peripheral tissues. Unlike gonadal androgens, ACTH regulates adrenal androgen formation, thus, excess secretion can occur either as a pure syndrome or as a component of Cushing disease. The adrenal causes of androgen excess include adrenocortical neoplasms and a group of disorders that have been designated congenital adrenal hyperplasia. Adrenocortical neoplasms associated with virilization are more likely to be androgen-secreting adrenal carcinomas than adenomas. Such tumors are often also associated with hypercortisolism. They are morphologically identical to other cortical neoplasms and are discussed later. Congenital adrenal hyperplasia stems from several autosomal recessive inherited metabolic errors, each characterized by a deficiency of a particular enzyme. Figure 24.46 Consequences of C21 hydroxylase deficiency. 21-hydroxylase deficiency impairs the synthesis of both cortisol and aldosterone at different steps. The resultant decrease in feedback inhibition causes increased secretion of adrenocorticotropic hormone, resulting ultimately in adrenal hyperplasia and increased synthesis of testosterone. The sites of action of 11, 17, and 21-hydroxylase are shown as numbers in circles, involved in the biosynthesis of cortisol. Steroid precursors that build behind the defective step in the pathway are channeled into other pathways, resulting in increased production of androgens, which accounts for virilization. Simultaneously, the deficiency of cortisol leads to increased secretion of ACTH culminating in adrenal hyperplasia. Certain enzyme defects may also impair aldosterone secretion, adding salt wasting to the virilizing syndrome. Other enzyme deficiencies may be incompatible with life or, in rare instances, may involve only the aldosterone pathway. Hydroxylase deficiency is by far the most common genetic cause of CAH, accounting for over 90% of cases. Figure 24.46 illustrates normal adrenal steroidogenesis and the consequences of 21-hydroxylase deficiency, which varies in severity depending on the nature of the CYP21A2 mutation. Three distinctive syndromes have been described: salt-wasting adrenogenitalism, simple virilizing adrenogenitalism, and non-classic adrenogenitalism. The salt-wasting syndrome results from an inability to convert progesterone into deoxycorticosterone because of a total lack of 21-hydroxylase. Thus, there is virtually no synthesis of mineralocorticoids, and concomitantly, there is a block in the conversion of hydroxyprogesterone into deoxycortisol, resulting in deficient cortisol synthesis. This pattern usually comes to light soon after birth. As in utero, electrolyte and fluid balance can be maintained by the maternal kidneys. There is salt wasting, hyponatremia, and hyperkalemia, which induce acidosis, hypotension, cardiovascular collapse, and possibly death. The concomitant block in cortisol synthesis and excess production of androgens, however, lead to virilization, which is easily recognized in the female at birth or in utero. Males with this disorder are generally unrecognized at birth but come to clinical attention 5 to 15 days later because of salt loss, hypotension, and other abnormalities. Simple virilizing adrenogenital syndrome without salt wasting occurs in approximately 1/3 of patients with 21-hydroxylase deficiency. These patients generate sufficient mineralocorticoid to prevent a salt-wasting crisis. However, the lowered glucocorticoid level fails to cause feedback inhibition of ACTH secretion. Thus, the level of testosterone is increased, with resultant progressive virilization. Non-classic or late-onset adrenal virilism is significantly more common than the classic patterns already described. There is only a partial deficiency of 21-hydroxylase, which accounts for the later onset. Individuals with this syndrome may present with mild manifestations such as hirsutism, acne, and menstrual irregularities. Non-classical CA cannot be diagnosed on routine newborn screening, and the diagnosis is usually made by demonstration of biosynthetic defects in steroidogenesis. Morphology. In all cases of CA, the adrenals are bilaterally hyperplastic, sometimes increasing to 10 to 15 times their normal weight because of the sustained elevation in ACH. The adrenal cortex is thickened and nodular, and on cut section the widened cortex appears brown because of lipid depletion. The proliferating cells are mostly compact, eosinophilic, lipid-depleted cells intermixed with lipid-laden clear cells. Hyperplasia of corticotroph cells is present in the anterior pituitary in most persons with CAH. Clinical features. The clinical features of these disorders are determined by the specific enzyme deficiency and include abnormalities related to androgen excess, with or without aldosterone and glucocorticoid deficiency. CAH also affects the function of the adrenal medulla. Specifically, high levels of intraadrenal glucocorticoids are required to facilitate medullary catecholamine synthesis. In patients with severe salt-wasting 21-hydroxylase deficiency, a combination of low cortisol levels and developmental defects of the medulla profoundly affects catecholamine secretion, further predisposing these individuals to hypotension and circulatory collapse. Depending on the nature and severity of the enzymatic defect, the onset of clinical symptoms may occur in the perinatal period, later childhood, or, less commonly, adulthood. For example, in hydroxylase deficiency, excessive androgenic activity causes signs of masculinization in females, ranging from clitoral hypertrophy and pseudohermaphroditism in infants to oligomenorrhea, hirsutism, and acne in postpubertal females. In males, androgen excess is associated with enlargement of the external genitalia and other evidence of precocious puberty in prepubertal patients and oligospermia in older males. CAH should be suspected in any neonate with ambiguous genitalia. Severe enzyme deficiency in infancy can be a life-threatening condition with vomiting, dehydration, and salt wasting. Individuals with CAH are treated with exogenous glucocorticoids, which, in addition to providing glucocorticoids, also suppress ACH levels, and thus decrease the excessive synthesis of the steroid hormones responsible for many of the clinical abnormalities. Mineralocorticoid supplementation is required in the salt-wasting variants of CAH, with the availability of routine neonatal metabolic screens for CAH and the feasibility of molecular testing for antenatal detection of 21-hydroxylase mutations. The outcome for even the most severe variants has improved significantly. Key concepts: adrenogenital syndromes. The adrenal cortex can secrete excess androgens in either of two settings: adrenocortical neoplasms or congenital adrenal hyperplasia. CA consists of a group of autosomal recessive disorders characterized by defects in steroid biosynthesis. Usually cortisol, the most common subtype, is caused by deficiency of the enzyme 21-hydroxylase. Reduction in cortisol production causes a compensatory increase in ACH secretion, which in turn stimulates androgen production. Androgens have virilizing effects, including masculinization in females, precocious puberty in males, and, in some instances, salt wasting and hypotension. Bilateral hyperplasia of the adrenal cortex is characteristic, and a subset of hydroxylase-deficient patients also demonstrates adrenomedullary dysplasia. Adrenocortical insufficiency. Adrenocortical insufficiency or hypofunction may be caused by primary adrenal disease or decreased stimulation of the adrenals due to a deficiency of ACH. Three major patterns of adrenocortical insufficiency are recognized: primary acute adrenocortical insufficiency, primary chronic adrenocortical insufficiency, and secondary adrenocortical insufficiency. Primary acute adrenocortical insufficiency. Acute adrenal cortical insufficiency occurs in a variety of clinical settings. In individuals with chronic adrenocortical insufficiency, a crisis may be precipitated by any form of stress that requires an immediate increase in steroid output to maintain homeostasis. In patients maintained on exogenous corticosteroids, in whom rapid withdrawal of steroids or failure to increase steroid doses in response to an acute stress may precipitate an adrenal crisis because of the inability of the atrophic adrenals to produce glucocorticoid hormones. Table: adrenocortical insufficiency, primary insufficiency, loss of cortical cells, congenital adrenal hypoplasia, X-linked, adrenal hypoplasia, adrenoleukodystrophy, autoimmune, adrenal insufficiency, autoimmune, polyendocrinopathy syndrome type, autoimmune, polyendocrinopathy syndrome types and infection, acquired immune deficiency syndrome, tuberculosis, fungi, acute hemorrhagic necrosis, amyloidosis, sarcoidosis, hemochromatosis, metastatic carcinoma, metabolic failure and hormone production, congenital adrenal hyperplasia, drug and steroid-induced inhibition of ACH or cortical cell function, secondary insufficiency, hypothalamic, Pituitary disease neoplasm, inflammation, hypothalamic pituitary suppression, long-term steroid administration, steroid-producing neoplasms, ACH, adrenocorticotropic hormone. As a result of massive adrenal hemorrhage, which damages the adrenal cortex sufficiently to cause acute adrenocortical insufficiency, as occurs in newborns following prolonged and difficult delivery with considerable trauma, and hypoxia. It also occurs in some patients maintained on anticoagulant therapy, in post-surgical patients who develop disseminated intravascular coagulation and consequent hemorrhagic infarction of the adrenals, and as a complication of disseminated bacterial infection. In this last setting, it is called Waterhouse-Friderichsen syndrome. Waterhouse-Friderichsen syndrome. This uncommon but catastrophic syndrome is characterized by the following: overwhelming bacterial infection, classically Neisseria meningitidis septicemia, but occasionally caused by other highly virulent organisms, such as Pseudomonas species, pneumococci, Haemophilus influenzae, or even Staphylococci. Rapidly progressive hypotension leading to shock. Disseminated intravascular coagulation associated with widespread purpura, particularly of the skin. Rapidly developing adrenocortical insufficiency associated with massive bilateral adrenal hemorrhage. Waterhouse-Friderichsen syndrome can occur at any age but is more common in children. The basis for the adrenal hemorrhage is uncertain but may be due to direct bacterial seeding of small vessels in the adrenal, the development of disseminated intravascular coagulation, or endothelial dysfunction caused by microbial products and inflammatory mediators. Whatever the basis, the adrenals are converted to sacs of clotted blood, which obscures virtually all of the Figure 24.47 diffuse purpuric rash in a patient with Waterhouse-Friderichsen syndrome. 751.3 to 751.5. 2009. Figure 24.48 Waterhouse-Friderichsen syndrome. At autopsy, the adrenals were grossly hemorrhagic and shrunken. Microscopically, little residual cortical architecture is discernible. Underlying detail. Histologic examination reveals that the hemorrhage starts within the medulla near thin-walled venous sinusoids, then suffuses peripherally into the cortex, often leaving islands of recognizable cortical cells. Prompt recognition and appropriate therapy must be instituted immediately, or death follows within hours to a few days. Primary chronic adrenocortical insufficiency. In an article published in 1855, Thomas Addison described a group of patients suffering from a constellation of symptoms including general languor and debility, remarkable feebleness of the heart's action, and a peculiar change in the color of the skin associated with disease of the suprarenal capsules, or in more modern parlance, the adrenal glands. Addison disease, or chronic adrenocortical insufficiency, is an uncommon disorder resulting from progressive destruction of the adrenal cortex. Typically, clinical manifestations of adrenocortical insufficiency do not appear until at least 90% of the adrenal cortex has been compromised. The causes of chronic adrenocortical insufficiency are listed in Table 24.10. Although all races and both sexes may be affected, certain causes of Addison disease are much more common in Caucasians and in women. Pathogenesis. A large number of diseases may affect the adrenal cortex, including lymphoma, amyloidosis, sarcoidosis, hemochromatosis, fungal infections, and adrenal hemorrhage. But more than of all cases are attributable to one of four disorders: autoimmune adrenalitis, tuberculosis, AIDS, or metastatic cancers. Autoimmune adrenalitis accounts for 80% to 90% of cases of primary adrenal insufficiency in high-income countries. As the name implies, there is autoimmune destruction of steroidogenic cells, and autoantibodies to several key steroidogenic enzymes are detected in the majority of patients. Autoimmune adrenalitis occurs as an isolated condition in 40% of cases, or as part of an autoimmune polyendocrinopathy syndrome in the remaining 60%. The latter encompasses several distinct entities. APS1, also known as autoimmune polyendocrinopathy, candidiasis, and ectodermal dystrophy, is characterized by chronic mucocutaneous candidiasis and abnormalities of skin, dental enamel, and nails in association with a combination of organ-specific autoimmune disorders that result in immune destruction of target organs. APS1 is caused by mutations in the autoimmune regulator gene on chromosome 21q, areas expressed primarily in the thymus, where it functions as a transcription factor that promotes the expression of many peripheral tissue antigens. Self-reactive T cells that recognize these antigens are eliminated. In the absence of error function, central T cell tolerance to peripheral tissue antigens is compromised, promoting autoimmunity. Individuals with APS1 develop autoantibodies against IL-17 and IL-22, which are the principal effector cytokines secreted by TH cells. Because these two Th cytokines are crucial for defense against fungal infections, it is not surprising that patients develop chronic mucocutaneous candidiasis. APS usually starts in the fourth decade of life and presents as a combination of adrenal insufficiency and autoimmune thyroiditis, with or without TD. Unlike in APS1, mucocutaneous candidiasis, ectodermal dysplasia, and autoimmune hypoparathyroidism do not develop. Overall, APS2 is more prevalent than APS1. In contrast, APS4 is a rare condition characterized by adrenalitis plus other autoimmune phenomena but neither thyroiditis nor T1D.